So good morning, everyone. Welcome to this ConnAction Session on prostate MRI. It's a great pleasure for me to be here with real leaders in prostate imaging and therapy. So this session will be early stage prostate cancer, developments in imaging and treatments, recommendations for clinical practice and directions for the future. So we'll now start very quickly with a real expert in imaging, Professor Jelle Barentsz, please.
Thank you. Okay, what do I would like to emphasize? I will cover image acquisition, interpretation, contrast MRI, what should I contour, and a few words on screening. Quality first. We have a high workload. Hurry, hurry, hurry. Speed up, but I have a warning. If we speed up, we will not be using fully specialized radiographers. We will not be using prostate radiologists. We won't have an MDT review. We will have suboptimal techniques, bad biparametric MRI or fast MRI. Okay, this is a case I see too often. 54 years old, elevated PSA density above 0.15. A 3T MRI was performed according to the technical requirements. And what's your Barentsz score? Well, I would say on the T2, there is erased charcoal in a large lesion. So this is a Barentsz 5. What does it mean? Biopsy. So a transrectal biopsy was planned. But the patient looked at this wasp nest and he said, no, I will have a second opinion MRI. And here you see on the left the second opinion MRI. And what do we see? Hey, like putting on glasses. There are many lesions well demarcated, so instead of a Barentsz 4 or 5, it is a 1. And that means no wasp nest, no biopsy. This was happening about 5 years ago. The patient's PSA still is at the same level. A blurry scan, novice eyes, will make the patient cry. And thus, you need to make a good MRI, what you now see on the right. Are MRIs good everywhere? Well, I think yes. I live in a nice country where there is a widespread availability of prostate MRI. However, despite the adherence to Barentsz version 2.1 guidelines, the quality is insufficient for optimal imaging. In how much? In 30% of multiparametric MRI and in 50% of biparametric MRI. And 75% of the centers are not using contrast. These scans were PiQual 1, inadequate. In the UK, it was not better. And recently, a nice presentation of Bembrilla showed that if you have a central review of the MRIs that were referred to his expert center, you saw that with a low quality, there was a significant number of more reclassifications. PiQual 1-2, poor quality, 47%, and 31% of reclassification in PiQual 3. And the repeat PiQual 1 scans was advised to be done if there is a diagnosis of uncertainty Barentsz 3+4. Okay. PiQual version 1 was published a few years ago, and now we have 2. First of all, it is mandatory for every radiologist in Europe to report his image quality. And for that, he can use the PiQual version 2 score. This is an image quality evaluation independent from technique and lesions. And it's a 3-point Likert score to make a separation from Barentsz. This is it. You can read it. And you can see the examination is either optimal, acceptable, or inadequate. What and how can we use AI? On the left, you see images that were made not with AI, and you can see the imaging time. And with AI techniques, we can speed up and have a higher delineation, a higher quality. So this is good. We are sharper and we are faster. And that is how we can use AI. Perhaps in the future, AI will replace PiQual to evaluate our quality. I think we're not that far from that, perhaps 5 to 10 years. Interpretation. This is all we have with the scoring systems. And to put it on a line, you have PyQual for image quality, Barentsz for the interpretation and technique, PIR for the post-prostatectomy and post-radiotherapy recurrences, and a few new ones. Those are the PyFab and the Target and the Precise. The first two for focal therapy recurrences and Precise for active surveillance. These are the two papers by Dejanti and Light. There is a difference. Target is more transatlantic and the specificity is higher, sensitivity lower, but the difference is not that much. Contrast should be used in these MRIs. So for a recurrence of focal therapy, always use contrast. Active surveillance, there is an update of the Precise criteria where you can score the progression or regression of a lesion. Here, DCE is recommended. DCE, the question is to DCE or not to DCE? Well, it is at this moment not to DCE. There are many papers that we should forget about contrast. However, in certain cases it is good. And are we throwing away the baby out with the bathwater? Be careful. This is a 65-year-old man, elevated PSA. And you can see that there is a lesion which is abnormal at T2, abnormal at diffusion. And this lesion has a rapid enhancement and washout. So the scoring is 4+. This means Pyrad 4. However, there is a wash in and wash out. So this means, according to a very old paper of Eline Vos in 2013, but also according to our experience in the Andros clinics, that when you have such an enhancement, arterial-like curve, there's a high probability of a Gleason 4 component. And this patient has a 3+4. If you don't see this enhancement, it is likely to be a 3+3. Contouring, I'm almost done. How should we contour a lesion? We can do it in different ways. This is a patient, and I will show you why we should consider in doing it in a certain way. A T2 and a diffusion-weighted abnormality, Pyrad 4, biopsy was performed. This was a significant cancer, 4+3. However, prostatectomy showed a larger tumor and a 3+4. What is going on over here? Is MRI bad? Well, the answer is that around the 4 lesion, there was a Gleason 3 component. So this was an insignificant area of tumor, non-aggressive, and in the center there was a Gleason 4. So we see the aggressive component. And this means that how should we contour this lesion? A lesion in the transition zone at 11 o'clock, mid-prostate, with a clear ABC and B2000 abnormality. Should we contour it this way? This is the lesion, anatomically. Or should we focus on the diffusion abnormality? Well, if you focus on the diffusion abnormality, like in this patient, you will have the hot spot, and this was a Gleason 3+5 component. So in the core, with an abnormality of diffusion, there you have the most aggressive part. So the question to my colleagues, treating physicians, is how should we contour? Screening. A few words on screening. In Europe, we have the do not harm approach. That means less biopsies and no overdiagnosis. That means we need to have a high specificity reading and a rather low sensitivity reading. This is how it can be done with a short protocol. This is a specific but not that sensitive protocol. It consists of a T2 axial and a B1400. You can plot it into one image. The orange part is the diffusion abnormality, and you can see a lesion, and it combines the T2 with diffusion. One image, one series of images to look at. No contrast, 10 minutes. That means that this is around 100 euros. Good news. What is the advice of the EAU for screening? It is a risk stratified screening. That means we start with elevated PSA on the left. Then we do the risk calculator, which consists of the PSA density predominantly. If that is positive, then we do an MRI. And when the MRI has been done, Pyrad 1, 2, 3, or 4, or 5, we perform a post-MRI risk calculator, and then the patient refers to biopsy. This is the modern screening. Now, the question to me, from me to my colleagues is, how can I, as a radiologist, help you with the problems you have in daily practice or in the future practice? With this was my short introduction. Thank you very much for your attention.
Having me at the Congress today. Last time I came was 10 years ago, and a lot has happened, and it's always with trepidation that anybody follows Professor Barentz's talk. So I'm a urologist. I was asked to give the urologist perspective, but it's really a urologist perspective, mine, and I don't necessarily represent all of my fraternity. I have a number of conflicts of interest that need to be declared. So I'm just going to frame my presentation with a number of issues, number of problems. So is the pre-biopsy MRI pathway reproducible? And I think this is something that's been touched on by Professor Barentsz. This is the West London rapid pathway where we delivered straight after promise was reported pre-biopsy MRI, and then a decision was made to biopsy based on the MRI findings. And as you can see, between the 3 pilot centres, we now have about 7 or 8 centres in West London delivering this pathway. There was consistency when you quality checked the MRI and the reporting and the biopsy decision making. So very low rates of biopsy, very low rates of grade group 1 disease, and consistent grade group 2 or higher disease. Is there still a role for systematic biopsies? And I think we haven't really answered this, but what we do know is that the risk stratification that we get with different types of biopsies is changing. And this is leading to a Will Rogers phenomenon where we are finding higher grade disease and we are classifying men as intermediate or high risk disease or unfavorable disease based on targeted biopsies through the middle of a tumor, and this might actually lead to overtreatment and unnecessary overtreatment. So we do need to reclassify, recalibrate our risk stratification systems. This is a study from comparing trust biopsy to targeted biopsies, and as you can see, quite a few, a minority, but quite a few men on targeted biopsy were found to have higher risk disease. This might be a good thing, but equally, it might lead to overtreatment. Equally, we need to adjust our classification systems because all of our classification systems have so far, henceforth, been based on a random systematic trust biopsy, not on the MRI pathway. Do we need contrast? Do we need image fusion? And I think we really have to wait for more evidence. I agree that there is heterogeneity in terms of expertise and skill base, and the Pacific trial is randomizing between 2,000 and 3,000 men between biparametric and multiparametric MRI, and those who have a lesion will then be randomized between visual registration targeted biopsy and image fusion. And this is a multi-center, quality-controlled study with Professor Padani and Professor Rockwell as the lead radiologists guiding centers in their quality checks and reporting. Can we improve active surveillance? As you can see from these guidelines, the guidance for how we carry out active surveillance is heterogeneous. It's very confusing, and it's confusing for men, it's confusing for physicians. And really, there's a big piece of work to be done here. How often do we do PSAs? Do we need to do regular biopsies? How often, and if we do MRIs, how should we do those MRIs? So there's quite a few questions here, but it's quite clear that tumor visibility is important. So if you look at this series from UCLH in London, led by Caroline Moore, it shows that Gleason 3+4, which is non-visible, at least on active surveillance in this study, behaves in a similar way to Gleason 3+3, which is visible, or Gleason 3+3, which is not visible. But the visibility really comes into its own when it's 3+4, which is that green line you can see in terms of treatment failure or transition to active treatment. And this is the GAP3 consortium, again showing tumor visibility is really important. So we have funding from the NIHR in the UK to carry out a 12 100-patient randomized control trial comparing a PSA-guided active surveillance program, which is what NICE recommend in the UK, versus regular MRI scans. If you have a visible lesion or grade group 2, you have an MRI scan every year. And if it's non-visible and grade group 1, an MRI every 2 years. And we will be measuring progression at 5 years in 1,263 men. So we've started to recruit already. And again, the quality checks on these MRIs is being led by Professor Panwani of UCL and Dr. Francesco Giganti of UCL. Focal therapy. So this is an emerging area, and we have a lot of data now demonstrating that this is safe and effective over a 10-year follow-up period. And one of the extraordinary things that we seem to be doing is we expend so much energy, time, effort, resources to finding that index lesion. We then throw all of that effort away by treating the whole prostate, and it doesn't make sense. It doesn't make sense, and it's never really made much sense. The comparative side effects of these various approaches are significantly different. So a 5 to 10-fold lower risk of genitourinary side effects and rectal toxicity compared to radical treatments. And certainly in the medium to early, to 5 to 10-year outcomes in terms of survival and salvage rates are very reassuring. We now know that these rates, certainly for surgery, are much worse than this table quoted. So the True North Movember study and the PACE randomized controlled trial showed much higher rates of incontinence after surgery. So we need to be honest with our patients. Focal therapy is not an alternative to low-risk disease. This is the HIFU registry, and as you can see, the green bar is very small. That's low-risk disease. This is cryotherapy. Again, the ICE registry in the UK, you can hardly see the green bar. We hardly ever treat low-risk disease. And certainly we don't have randomized controlled trial data. Whenever we've tried, and there have been now 3 to 4 attempts to randomize between radical and focal therapy, and men just don't want to take part in the study. So we have to turn to other forms of comparative data, propensity match studies showing very similar outcomes compared to prostatectomy and compared to radiotherapy as well over a 5 to 10 year period. We do need to get more information from the MRI scan. So we need to work out what the margin of treatment should be. In a small lesion, we can apply a smaller margin of treatment. In a larger lesion, we need to apply a larger margin, maybe up to 10 millimeters around the lesion. We then do need to work out how best to report MRIs after focal therapy, and the Target and PIFAB teams are joining together. We've announced that recently, and we will be coming up with a consensus approach going forward. Sorry, can we advance, please, to the next slide? Here we go. So finally, what about screening? So everybody's talking about screening. Could we advance, please? I don't think we've got there yet. I think there's a lot to be done in terms of the best approach to finding cancer, which is significant, and we need to do much more to reduce the side effects of treatment. Next slide, please. So the prostagram study demonstrated in about 410 men who were screened with a short prostagram MRI biparametric. Next slide, please. And we found that if you used an MRI score of 4 or a high PSA density for a score of 3, MRI, prostagram, found more significant cancers than PSA. Next slide, please. Can we just click along until... So as you can see from this graph, the rates of biopsy versus significant cancer diagnoses depends on the PSA thresholds and depends on the MRI thresholds you use. Click again, please. And the optimal approach seems to be a PSA of 1, followed by a prostagram MRI and biopsy if it's scored 4. Next slide, please. And so we've set up the Transform study, which is a big screening trial in the UK. Next slide, please. And this is set up in 3 stages. The first stage will pilot various ways to screen for prostate cancer. Next slide, please. And keep on clicking through. And another click and another click. Thank you. Sorry about this. So we're looking at 4 different approaches in the first stage in 12,500 men who will be randomized between these different arms. And we will see which is the best approach in terms of biopsy rates, in terms of significant cancer, insignificant cancer, and toxicity and adverse events. We are only going to do targeted biopsy. We are not going to permit systematic biopsy. And let me leave you with this slide. If Transform shows that MRI prostagram should be used as a screening tool instead of, or perhaps in addition to PSA, you are going to have a lot of work on your hands. And we're going to need the radiology fraternity to help us overcome this burden and healthcare issue. Thank you very much.
Slides. The radiation oncologist perspective on early prostate cancer is a difficult subject, and I will go through 5 bullet points and then elaborate on them. So first of all, when we talk about early stage prostate cancer, we are talking about active surveillance. And for vast majority of patients, we're actually interested in deferring the treatment, and we're going to be successful in that based on the available data in more than half of the patients. Second, MRI and PSMA PET are here to stay. They are the current standard of change. They have been game changers, but it's not a question of if we are going to use them, we are going to use them. It's a question of how fast will they become readily and widely available so we can use them for all the patients if we need to. MRI has become a standard tool in radiation therapy for target delineation for treatment planning, and it has its many benefits. It has some downsides, but mostly benefits. And PSMA PET, of course, excels at identifying distant metastases. What we know by now, not so much local regional metastasis, but that's another topic. Finally, both are very, very useful for guiding salvage treatments. Now, starting from the active surveillance, and that was the first point at which I thought, how could we communicate between the disciplines and what can we do to bridge between the clinical and the clinical contact with the patient and in the interpretation of the images. Active surveillance is a tool which aims to de-escalate the treatment. And a problem we often notice with active surveillance is that we tend to overdo it. We have patients that receive 2-3 MRIs per year because there was something suspicious on the MRI. They come for the PSA checkups much more often than they should. Now, I think what is sometimes missing in the communication is that if we have that patient who is at very low risk of progression, is a very, very low risk of dying from a prostate cancer, and we have good data based on studies we did minimal follow-up, that perhaps we should really think if we should be suggesting in the MRI that the patient should get another MRI, they should get more diagnostics, or we should really think about the fact that this is a treatment which aims to de-escalate the patient burden, because every visit, every imaging is going to be a burden on the patient's quality of life and a lot of stress. When it comes to the local staging, now, as I said, active surveillance, in my opinion, is the way to go for vast majority of the patients with early prostate cancer, certainly all patients with low-risk disease, many of those with intermediate too. Now, we have important tools that we can use to combat the higher risk of recurrence in a patient. We have the ASCEND-RT trial, which showed that brachytherapy boost can significantly reduce biochemical recurrence, and recently we had the FLAME trial. Now we have the HypoFlame trial ongoing. By now, I think every center should have an option for boost, focal or whole gland available. Recently, we also had this STAMPEDE GR, which showed that adding abiraterone in patients with very high risk of recurrence significantly reduces the risk of death by about 40%. The advanced imaging is useful only if we actually follow it up with a treatment change, because despite all that options, we know for sure that we still very often use the one-size-fits-all approach, where we have that one hypofractionated whole prostate option, what we're going to use despite anything we find on the imaging. So I think the very important thing in performing the advanced imaging is that we actually have to follow it up with a treatment adjustment in case if we find something that's concerning. When it comes to the defining target volumes, this is a concept that has been in radiation oncology for quite some years. And in 2018, the ESTRO issued recommendations on prostate delineation with MRI, and which followed 3 years later with the same thing for prostate bed. This is very important. However, we also need to understand that radiation therapists, many of us, and that I'm being very honest right now, we are not so good at interpreting the MRIs. So within the centers, I believe it's very, very important that it should be a collaborative effort. It should be something that we are able to consult with you when we have the MRI and we are not quite sure what we are finding on it, but we are able to consult with a radiologist and to actually improve the treatment through increased precision rather than just having the MRI but not being quite sure what we find on it. And now this is going to be increasingly more important because of the aforementioned flame trial and hypoflame trials, which I believe to be transformative for the radiation therapy field. When it comes to PSMA PET, again, this is nuclear imaging. However, it certainly transformed prostate cancer care when it comes to radiation therapy. I think there is a pitfall. With modern state-of-the-art imaging, what we tend to do when we find additional lesions, and of course, as mentioned previously, we're going to have stage shift. We're going to find more patients with early conventionally subclinical metastases. Now, when we find those lesions, we are still treating the patients based on paradigms developed on conventional imaging. Also, what we try to do, we take the shortcut to metastasis-directed therapies. However, I would like to stress it that for the backbone of treatment for all patients with proven metastasis on imaging is systemic therapy. And we have a lot of systemic therapies that have been proved to prolong the life of the patients and significantly reduce the risk of progression. And that part, which we do then with the things that we see, is an addition. Up till now, unfortunately, there is still no trials showing survival benefit for metastasis-directed therapies in patients with de novo diagnosed synchronous metastatic prostate cancer. I am aware of the ASCO-GU analysis of the STOMP, Oriole, and EXTEND trials. However, that was a very specific case of deferring ADT or intermittent ADT, in which none of the patients in the control arms did actually receive a treatment we would now consider a standard of care for a patient with synchronous metastatic hormone-sensitive prostate cancer. Now, finally, both MRI and PSMA PET are valuable tools for guiding salvage treatments. But there are some caveats. As we know from the PRO-PSMA trial, for example, the accuracy is better than conventional imaging for detecting metastasis. However, we also know that the sensitivity is not that high. And that has been shown, for example, in the trial by Hope et al. From 2021, but recently also shown clinically in the PS5 STORM trial shown last year on ESTRO. We are actually missing a lot of the lymph node lesions, and we have to take that into consideration and not to have too much hubris with what we think we know about the disease. Again, both with the MRI and PSMA PET, we can find the lesions, but there is the biggest change between the legacy trials in salvage treatments after radical prostatectomy from the 80s and 90s, and the JETUC-17 trial, the Radical 30 trial, the RAVES trial, the SP-PORT trial, was actually the difference in the baseline PSA, which came down from 1.2 to 0.1, 0.2. And with that, we are already able to achieve excellent results, a durable disease control in over 90% of the patients alone. Now, in a case, if we have a patient coming after radical prostatectomy with a rising PSA, let's say at 0.1, and we have the option to initiate a treatment that has over 90% probability of being successful, or waiting 1 to 3 months, depending on how much time we need for the additional imaging, we unfortunately, unintentionally, we can actually decrease the patient's chance for cure, because the biggest driving factor so far that we know for the probability of cure is the PSA, is a PSA at which we start the salvage treatment. And this is also why it's called early salvage approach. So I would like to stress that if we have that readily available, if we can do that within a week, within 2 weeks, of course, that makes sense. But in many cases, if we were to postpone the treatment for months, then it might be better in those cases not to do it. Thank you so much.
Handing the microphone over to Dr. Messina, who will somehow guide the panel discussion. I would like to remind that this is a multidisciplinarity session. So probably the most important part of it is somehow transmit to the audience that multidisciplinarity is essential in any disease, but especially in this setting in which there could be really difficult or many reasons to have a wider approach and use of or diffuse use of MRI as a screening test or for early detection in prostate cancer. So multidisciplinarity is essential in all our activity, but especially, I would say in this one here. Please, Emanuele.
So, good morning, everybody. And first of all, I would like to bring you all greetings from Professor Panebianco, who unfortunately got a very bad flu and she couldn't come here. So, I would like to go back to one of the points mentioned by all of you, prostate cancer screening. To date, the EU guidelines still don't recommend to introduce MRI as initial screening tool. But what do you think could be the real potential role of MRI in the screening setting, and which could be, according to your experience and knowledge, the best pathway for prostate cancer screening?
I think still a lot of studies need to be done to answer that question adequately. You can do an upfront MRI, but that places an enormous burden on the MRI capacity. And what the EAU is advising is do a PSA. And when you have an elevated PSA, do a risk calculator that usually is using the PSA density. And if the PSA density is elevated, then do an MRI. With that, you will save an enormous numbers of MRI. And the patients who will benefit from screening, they will get an MRI. On the other hand, with that strategy, of course, you will not find all the cancers. But the question is, and that's the question also to the urologist, is our system able to afford to do an MRI in all the patients that are over an age of 50 or in between 50 and 70, even if we use a fast MRI?
It's a really important question. So whatever we do, if screening is delivered in any European country, the system will come under huge strain. So there's no doubt you will need to make capital investments in scanners. You will need to start now to increase the number of medical students, the number of qualified doctors going into radiology, and you're going to need to see where the AI landscape goes to see if that can reduce your burden. But the political decision to invest has to follow the evidence. And at the moment, I know the EAU is pushing for screening, but the evidence doesn't really support the mass screening of individuals. There is a simplicity associated with doing a prostagram in everybody. Mammograms, low-dose CTs, colonoscopy is a little bit different. You start off with a FIT test, but most screening programs have an imaging-based pathway, and there's a simplicity associated. The more steps you introduce, the more complicated it becomes, the more people will interfere with that, and the more confusing it will be for not patients, but the population who are looking to participate. So I don't have an answer. Whatever we do, we're going to have to make massive tens, hundreds of millions of pounds investment. Recently, Lord Darzi wrote a report on the UK's NHS system, and he said it was broken. If we even double the rates of PSA testing in the UK, it will shatter our healthcare system. It will just overwhelm every single urology department, radiology department, oncology department will only be dealing with prostates and nothing else.
On the other hand, I think you're right. There is a heavenly burden on the healthcare system. But what we see nowadays is an enormous amount of opportunistic screening. Man, here at the birthday, that the guy has tested his PSA. He wants his have to PSA. He goes to the GP. The GP says, "Well, sir, do you really want that?" There's some discussion. After 5 visits, finally he gets his PSA. His PSA is elevated. Then he goes to the urologist. The urologist says, "Yes, sir, but you're 75. It doesn't really make a difference whether we find the cancer or not. So why should you do it?" But the man insists. Then he goes to an MRI. The MRI is not perhaps at good quality. The poor quality MRI is leading to overdiagnosis, etc., etc. That is the opportunistic way of doing prostate cancer diagnosis, putting a heavy burden on the GP as well as on the urologist, as well as on the radiologist. Yes. With an organized screening performed in a nice organized way, you will standardize the entire diagnostic path. And there will be an enormous decrease of opportunistic screening. So yes, you need to invest a lot of money. And the question is, can we do that at this moment? But you know that investment usually, if you do it well, leads to more profit. That's the reason of investing money. And I think, looking at the economical data, that the chance that there is money saved at the end is very high. However, the question is, can we afford it? You see, but giving money right away, from a political point of view, is very unpopular.
Yeah, so, if I can step in this discussion here, I think that us radiologists really do lots of inappropriate exams. So if we look at the numbers of exams that we do in MRI, okay, we're talking about MRI now, but we could talk of anything, okay, CT, whatever. If we look at the numbers we do with the MRI, we would see that probably, as we all know, 40% of exams are inappropriate. So we do really many that shouldn't be done, or for several reasons. So I think that a way of rethinking of the entire organization of radiology departments, of radiology administrative approach to the profession would be needed, because it's true. I mean, that having like diffuse screening would really practically make collapse any kind of healthcare system, independent where you are, Netherlands, Italy, UK, anywhere, Austria. But at the same time, one of the targets that we should have, one of the aims that we should have as radiologists is try and diffuse the concept and the culture that of appropriateness of exams. By doing so, I think we should have much more space to do exams that are really needed, and probably dedicate and do better exams. As you've shown, quality is essential. So it's much better to have those exams that are needed in very, very high quality rather than poor exams in some cases need to be repeated or done again.
May I make one remark? I think you're absolutely correct. And I think we need to have a quality measurement of the imaging that we do. We did that with mammography, with the screening, because with screening, the level of quality needs to be very high and it's being controlled by a central organization. Looking at the quality of the mammogram. Well, I took that concept and with the international group, we developed the PI-QoL, which is, I think, the first MRI standard looking at image quality, which is good. If we have a PI-QoL 1, It's bad. To my surprise, in my country, the numbers of PyQual were higher than I ever thought it would be. But now, for the first time, we see that we could deliver our job in a better way. So I think the first thing is have a standard. I now want to work with the breast guys and girls together to develop a BiQual for breast MRI, because there's also a high need for breast MRI in dense breast. So I think you're right. And as radiologists, we should not look at the diagnosis first, but at the quality of our exams. Do a benchmark. How good am I? How good is my neighbor? Make in your report a remark, my quality, I looked at it and is tuk tuk tuk. And then start with the diagnosis. I think if we do it that way, that will be good. Another thing, and I wrote a commentary in European Radiology recently, at this meeting, there are many scientific presentations. And it's fantastic. They're very smart studies. However, nobody mentions image quality. What's the quality of the images I used in my study? Nobody does. Even as reviewers in international journals, we are not looking at image quality. So why don't we have a prescription that you need to define your quality in a scientific paper, in a study?
Can I ask Jelle, we see a lot of papers now say all of our MRIs are PIRADS version 2.1 compliant. Do you think people are just throwing that into the methods, but not actually verifying that all of the scans were actually compliant with PIRADS version 2.1?
Yes, I think to some extent, but even if it matches the technical requirements, that does not guarantee a good quality image. Because it's not only the technical requirements, it's also the patient, the technician. So we should not look at the technical requirements. That was what PyQual version 1 did. But we should look just only at the image quality. Irrespective of the vendor, the technique used, age of the patient, we just should look at the quality. Also not looking, can we see a tumor? If you have a big PIRADS 5 tumor, you can even see it with a poor image quality. No, you just should look at the image quality. And that is what PyQual is doing. Looking at the T2 quality, looking at the diffusion quality, looking at DC quality. And then you can have the overall quality. So I think technical requirements are good. We need to fulfill them, but they're not the only thing.
Okay.
Yes.
So, yeah.
Yes, if possible, I would like to have a quick comment. So I completely agree that opportunistic screening is a problem, and it's a major problem, and it's also, unfortunately, a place in modern-day medicine where patients often can be exploited, especially in the setting of private medicine, and we see that a lot. However, while we're talking about cost efficiency and we're talking about efficiency overall, of course, the screening, it's a matter of dispute, the efficiency at saving lives. However, with screening, we are very efficient in turning healthy people into patients. And this is something we should also consider, that there's a major drawback for the people who would otherwise live their life without the diagnosis of a cancer. And now, if we do a systematic screening, they will have a diagnosis. And in many cases, it's a diagnosis that is just there, but will never need, it's not a disease that will ever need to be treated. Now, what I'm thinking is that this is in majority caused by patient distress. And it's both the patient distress who has diagnosis of a cancer, but he doesn't understand that it's a 5% of Gleason 3+3. It still says cancer. So the first thing is maybe we should finally address the elephant in the room and the diagnosis of ECP1. Is it a cancer? Should we call it like that? Maybe we should rename it a bit, at least a bit. And the second thing is there is an increasing opportunity for patient's assistant not actually requiring the patient to go to the GP or the urologist or the radiation oncologist. If we can integrate AI and, let's call it like the chatbots, into helping the patients understand what they see on their outcomes, maybe they will have less distress, they will have better quality of life, and they won't do that thing that we just described. So they won't go to the 5 consultations, do 5 additional tests, and do additional MRI, because they will be aware, they will be at peace with the information they have, because they won't worry so much, they will have more information. So maybe this is also something we can use in the future to reduce the burden on the society.
Okay. May I make one remark? I certainly agree that overdiagnosis, what we saw from the ERSPC trials in the 90s, is a nightmare. However, fortunately, with MRI and with modern MRI, we are defining and we're finding more significant cancers than the 3+3s. A 3+3 I do not see. You saw it on my image, and so it is a reduction. Still, there are a few patients who have a 3+3 detected even in screening, although it's a minority. But the good thing is this: there we have active surveillance. And now you will say, okay, the patient has a 3+3 and it's cancer. It's insignificant cancer, but of course, what the patient remembers is, I have cancer. What should I do? Well, then the urologist is saying, and the radiologist, we together are saying, okay, sir, you have an insignificant cancer that will not harm you. And we will check that with a yearly or once in 2 years, an MRI. And we will show the MRI to you on the screen. The new one, the old one. If something changes, we will do a biopsy, targeted, and we are in time. I think if you put it in that way, you may reduce anxiety. Or don't you agree as a urologist? Yeah. So that is a way to handle. And I completely agree, we should not create anxiety. PSA means prostate-specific anxiety. So you're absolutely right. So thank you for this.
Yeah, this goes back to what we say all the time as radiologists, communication. Communication is essential. We try and teach young ones. I think Jelle and I are old enough to say that. We try and teach everyone that communication, also for us radiologists, is essential to explain exactly how the situation is and try and avoid crazy situations that sometimes we need to face. Mm-hmm. But this is part of our job, I think.
You know how I learned communication? In the MDT.
Yes.
There you communicate with the urologist, with the radiation oncologist, with the pathologist, and that's good. Because with that, you know more what is behind the image, the patient. And even as a radiologist, I used to talk to patients. And my urologist was looking at me, you're a radiologist, why do you talk to patients? I said, well, I'm an MD as well. Why shouldn't I explain what is going on in his body? Knowing my limitation, I will never talk about the therapy which needs to be given because that is the MDT decision. Yeah, communication.
Absolutely.
That's important.
Yes, absolutely.
Among us and with the patients.
Yes.
Yes, of course. That's another question I wanted to ask you. Of course, a multidisciplinary approach is essential in all of these settings, but what do you think is the patient role in the decision-making? I mean, how much we should consider patients' concerns, and how would you approach this kind of topic?
So it depends on where you are in the pathway. So if you look at screening, the studies actually show, the modern day studies looking at screening, when you send out an invitation to a man to have a screening test for their prostate, only between 20 and 30% actually even reply. And then a small proportion don't even turn up. So a lot of men are voting with their feet in terms of screening, and there's something there. There's something about being scared about a cancer diagnosis, getting a letter talking about cancer, being scared about the biopsy, being scared about having a rectal examination, which they probably don't need anymore, being scared about the treatments. And we need to do much better in reducing the burden of biopsy, reducing the burden of treatments, and we need to be much more refined, as you said in your presentation, in how we deliver treatment. And that refinement and stratification is really important because it gets back to men. And so, I have a handful of men every year on active surveillance who we just lose to follow-up because they're terrified. And then they come back 2 years later with a PSA of 20 or 30 and they've progressed. So compliance is an issue. So that communication is really tough. You have to address people like myself, like Jelle, who are, like ourselves, we are educated, but the vast majority, from different socioeconomic demographics, different ethnicities, different cultures, different geographical, extents. So it's really tough. There's a huge body of evidence as to how we can communicate better. There was a study from New York by Bafar Erdai showing that if you apply a sort of a business model to communicating about active surveillance, you can triple your active surveillance decision. So men choose active surveillance rather than active treatment. So there's a lot there. And I just to add, the one person we're missing is a pathologist here. There's 10 to 20% inter-observer variability in how a pathologist assigns a Gleason grade. There's a huge argument about whether pathologists should call cancer grade group 1 cancer or not, and they are the people to decide, and only a minority at the moment agree with that change. But we need to convince more and more of them that we need to do this because attaching a label is a big part of communication as well.
Okay. And isn't it, well, everybody talks about shared decision making, but isn't it then the best way to decide in the MDT what's going to be done with the patient based on the clinical parameters, based on the MRI, based on pathology, and then look at what's the role of radiotherapy, focal therapy, urology, decision is made. And is it then, I think, the optimal way for the urologist to communicate that with the patient? And how do you do that in your clinic? This is something which is beyond my vision.
It's a 20 to 30, 40-minute consultation, especially if you have all of the options.
Yeah.
So if the majority of men are intermediate, grade group 1 in one index area with either nothing else or maybe a little spot of grade group 1. And so, the index, so you then talk about active surveillance because some of them could have active surveillance. You talk about focal therapy, you talk about radiotherapy, you talk about whether hormones are needed, you talk about prostatectomy. And the poor man, no matter how educated he is and their family is just overwhelmed. And then you say shared decision making is just I don't like the term because it puts all that pressure back on that man, and only a minority can really cope. And it's again unique in prostate cancer because we have so many options. Because it goes back to the root of the problem. The natural history is so favorable, you can do whatever you like. You can inject ethanol, you can inject all kinds of things into these prostates, and ultimately the man will survive. I say to men, you will make 10 years, you will almost certainly make 15 years in that intermediate risk group. You have to decide how you want to get there. And so we can help you, and we should be helping men make that decision. What is their priority? Is it sexual activity? Is it avoiding rectal toxicity because they have to pray? Is it incontinence because they're a builder? So we should be finding out more about them and saying, actually, this will be an impact on you. Or you come across like a really anxious person. Focal therapy, because we don't have 10 to 15-year data, maybe isn't the one for you. You should go for something more traditional. So I think we share decision-making, but we need to be doctors and we need to help people.
Okay. Unfortunately, we also encounter a problem, and I know this is very controversial, but there is this concept in ethics, it's called nudging. And in many cases, unfortunately, we are going to convince the patient that the best treatment is the treatment being done at the institution at which he is consulted. And this is quite a problem. And actually, I've heard a brilliant solution from Professor Pete Ost. I've been talking with him 2 weeks ago at a conference. He's one of the leaders when it comes to radiation oncology in prostate, no doubt about that. And he told me what they are testing right now is during the tumor boards, they are having again, I'm coming back to that subject, an AI processing everything that's being said, analyzing the cases, and then at the end of the consultation, the doctors come to an agreement. And the AI also gives a proposal. And when 85% of the times it aligns, but in 15% of the time, well, it has to be investigated why there is a discordance. But the thing, what is really concerning is that we are talking about an excellency center, a top center. But there's 740 million people living in Europe alone. And many of them will not be treated in the top centers.
Isn't then there... This argues for setting up private diagnostic centers where you also have a treatment decision. That's what we do in our clinic. The patient comes for a diagnosis and a treatment advice. And at the moment the treatment advice is given, the patient is with that advice, can go to any place where he wants. He can even be guided. So we have a team of urologists, we have a team of radiation oncologists, pathology, everybody on board. Then there is an advice, a second advice, a third advice. That's given to the patient in a discussion, not a... and with that the patient can make his decision. Isn't that a way to go? So build up centers of diagnostic and treatment advice excellence. We're not doing the treatment. Or is that a very difficult concept?
Jelle, just to give you an idea, I was in Brussels last week for a European Commission on behalf of the European Society of Radiology. And what came quite clear is that the European Commission is willing really to invest on screening centers all over Europe because they think it's extremely important, but not just imaging or centers, but centers, as you were saying, where people can be guided and go and indicate somehow which could be, for instance, their best treatments or somehow have guidance, because this is a crucial problem. We've seen now in prostate, but it's exactly the same for many other diseases. So we know that us radiologists are moving more and more towards screening tests and screening exams. So I think that there should be a guide for patients that may have different types of diseases, and somehow they should be indicated which could be the best test, or at least give advices, because I think that this is essential. So first, I'd like to thank all of you for being here. This has been a great session for me. I hope also for you, and especially for the audience. I've really enjoyed it. We have had exceptional speakers, radiologists, but radiation oncologists and urologists from all over Europe, and it's been a great session. Thanks a lot, and I wish all of you a very good Congress. Thank you.